So the first one is ductal carcinoma in situ. So this is mainly characterized by proliferation of malignant cells inside the milk ducts. Here there will not be any invasion, but it can converted to invasive ductal carcinoma. So invasive ductal carcinoma is most commonly seen, 80% of breast cancer. Here the tumor arises from the duct system and it will invade to the surrounding tissue. So here you can see the normal cells. There will be hyperplasia due to the causes, and it can lead to atypical ductal hyperplasia, and that can be converted to ductal carcinoma in situ. Here there will not be any invasion, but it can start with a micro invasion. Ductal carcinoma in situ can be converted into invasive ductal carcinoma later. Other one is invasive lobular carcinoma. It will start in the lobular epithelium, only 10 to 15%. Medullary carcinoma is very rare. Tumors in milk ducts, only 5%. Mucinous carcinoma, a mucin producer tumor, very slow growing tumor, only 3%. Tubular ductal carcinoma, here the ductal tube has been affected, that is also very rare, only 2%. And next is about inflammatory carcinoma, very rare but aggressive type. If it is occurring means it will be aggressive form, characterized by diffuse edema, pain, erythema, and it is termed as pudy orange. That means the skin of the breast will be resembled an orange peel, similar to this. Chemotherapy can control the disease, but surgery is needed for complete cure.
And next is about the diagnostic measures, starting with the medical history collection and asking about the breast self-examination results, or clinical breast self-examination can also be done by the doctor. So this should be normally carried out after the age of 20. And we can do ultrasound, breast ultrasound, MRI. Biopsy and mammography is commonly done procedures. And we can also do lymphatic mapping and sentinel node biopsy. Lymphatic mapping is by injecting dye into the lymphatic circulation. After that, we are taking a series of X-rays to finding out which all lymph node is being affected. Commonly, we can find out the most nearby lymph node, the first lymph node near to the tumor. That can be resected. It is termed as sentinel lymph node. Sentinel lymph node can be resected as a preventive measure to prevent spreading of the cancer from one lymph node to other lymph nodes. And other procedures like ductal lavage, we can insert a needle into the duct and inject fluid, and we can take it back or withdraw the fluid, and we can test that particular specimen for any cancer cells. Other tests are genomic tests like FISH test, fluorescence in situ hybridization, to find out the genetic material. By doing that, we can also find out HER2 marker, human epidermal growth factor receptor 2. If there is increased amount of HER2 marker, that is a positive sign for malignancy. Other genomic tests are Oncotype DX test, Mammostrat test, MammaPrint test. These all tests are done either to rule out the prognosis of the treatment and the disease, or either to rule out the recurrency level of the cancer. These are not commonly done. Commonly done are biopsies, mammographies, management, the mainstay management is surgery itself, but in some cases we can provide neoadjuvant therapy